Good afternoon, everyone, and thank you for joining Don't Get a Payment Penalty, Achieving QPP Reporting Success for Small and Rural Practices. My name is Leila Vlinsky. I am a Senior Program Administrator and New England Regional Lead for the Quality Payment Program work here at the New England Quality Innovation Network Quality Improvement Organization. I am very proud to be presenting this webinar today in collaboration with the New England Rural Health Roundtable as well as the New York Rural Health Association. So welcome. Next slide, please. As we get started this morning, I just want to let you know that we are CMS contractors. All of this material was created from CMS, or the Centers for Medicare and Medicaid Services content, but we did create these slides. Next slide. As a brief overview of what we'll cover this morning, I will briefly be talking about the Quality Payment Program. We'll talk about eligibility, the MIPS reporting cases, and I'll tell you more about what MIPS means, key decisions you should be making, the MIPS performance categories. We'll talk a little about the Program Year 2 final rule that just was released, some resources, and then, of course, time for questions at the end. Next slide. As many of you know, the Centers for Medicare and Medicaid Services like to use many acronyms. So some of the main acronyms you will hear me say today are QPP, which is the Quality Payment Program, MIPS, which is the Merit-Based Incentive Payment System, APMs are Alternative Payment Models, and ECs are Eligible Clinicians. Next slide. So, the Quality Payment Program was created through the Medicare Access and CHIP Reauthorization Act of 2015. Some of you may know that as MACRA. Part of MACRA also repealed the sustainable growth rate, which was a formula put into place many years ago to help curb Medicare spending. It posed upwards of 20% payment reductions for many clinicians. So having that sustainable growth rate removed definitely made the payments a little more standardized across the board. As part of MACRA also came the Quality Payment Program. The Quality Payment Program has two payment tracks. The first is the Merit-Based Incentive Payment System, or MIPS. The MIPS program consolidates three legacy reporting programs. The first is the Physician Quality Reporting System, or PQRS. The second is Meaningful Use, or MU. Some of you might know that as the Medicare EHR Incentive Program as well. And then there's also the Value-Based Payment Modifier, which was part of the PQRS program. All of those came together to form MIPS. The other payment track is Alternative Payment Models, or APMs. Under APMs, there's actually two additional tracks. So with the 2017 final rule last year, CMS created MIPS APMs. MIPS APMs are alternative payment models that don't take on both upside and downside risk sharing. They only take on that cost savings sharing. So those are typically the Medicare Shared Savings Track 1 ACOs. Under the APM model, there are also advanced alternative payment models. And again, these are alternative payment models that take on both upside and downside risk sharing. So if they don't perform at a certain level, CMS could continue to keep certain monies back from them. So there's that risk. Those are typically the Medicare Shared Savings Track 2 and 3 ACOs, Next Generation ACOs, practices in the Comprehensive Primary Care Plus or CPC Plus model, practices under the Comprehensive End-Stage Renal Disease model, and the Oncology Care model. Next slide, please. For rural health centers and federally qualified health centers, so RHCs and FQHCs, many of you are probably thinking, oh, great, I'm excluded from reporting under MIPS, or if I'm participating in an alternative payment model or an ACO, I don't need to worry about it. That's not always the case. So there's a couple of circumstances you should consider, and definitely look into your eligibility, which I'll talk about in just a minute. But if you bill all of your Medicare Part B services exclusively through that RHC or FQHC payment method, so that's that bundled payment, and more than likely you would be excluded from MIPS. That's because you're not billing directly to the physician fee schedule, so those payments wouldn't be eligible for a penalty. However, if you do bill your Medicare Part B services under that physician fee schedule, then you could be eligible for reporting under MIPS. In a minute, we'll talk a little more about eligibility, but you would need to meet that low volume threshold in order to be eligible, and we'll show you ways that you can look to see if you're eligible. Next slide, please. Another circumstance to consider is those clinicians that are part of critical access hospitals or CAHs. Really, depending on any of the methods that you submit your claims, you might be eligible, so it's really important that you take a look at the eligibility determination tool and see if you're included. So under the Method 1 billing, this means that all of your payment adjustments go through the Medicare Part B and they're billed right to the physician fee schedule. Again, you might be eligible. It's really important to look to see if you meet that low volume threshold. If you bill under Method 2 and you assign your billing rights to your CAH, then again, you might be eligible, but only that chunk of those payments that are used under the Method 2 would be eligible. If you don't assign your rights, then any portion of the Medicare Part B claims that are billed up to the physician fee schedule would be eligible for a penalty, and you might be included in reporting. Again, you have to meet the low volume threshold in order to identify if you need to report or not. Next slide, please. I'm actually going to jump ahead and watch an additional slide. Next slide. So as I mentioned on checking your eligibility, the CMS Quality Payment Program website, which you can see the link here, is https qpp.cms.gov. Right on the website, there's a tool where you can enter your 10-digit NPI or the NPI number of any of the clinicians that work in your practice. And CMS will put up a page that shows whether those clinicians are included in reporting under MIPS for 2017 or excluded. You might have also received the letter on the right-hand side. Those were mailed to practices in May, and they showed, based on the TIN, so the tax ID of your practice, all of the specific clinicians, whether they're included or excluded, and why. On this participation lookup tool, you'll be able to see every TIN that that clinician is associated with. We've had a number of questions about clinicians that practice in multiple sites and whether or not they need to report for all of those different sites. Short answer is, it's really hard to tell. It depends on the number of Medicare Part B claims the clinician furnishes at each of those 10 practice sites that they're at. If they meet the $30,000 claims threshold and they see at least 100 Medicare beneficiaries annually, that clinician would be included in reporting and would be expected to submit at least some data to CMS this year in order to avoid a 4% negative penalty. Now, if that clinician furnishes fewer than $30,000 in Medicare Part B claims or sees fewer than 100 Medicare beneficiaries, then they would be excluded. And that, again, might vary based on each of their practice locations, so it's really important to know how you participate in each location you might practice. Next slide, please. On this eligibility status lookup tool, there's also a section that talks about special status determinations. So if you move down the page, you'll see the special status per practice site the clinician's at. And as you can see, there's 5 different designations. The first is a non-patient facing clinician. So those are clinicians that furnish fewer than 100 patient-facing encounters during the reporting period. We've had a lot of confusion with this one. We've had some clinicians and practices that are sort of a primary care type practice that are showing up as non-patient-facing. That's because whatever encounter codes those practices are using to bill those encounters don't meet the requirements for the list that CMS has identified as patient-facing encounters. If you're questioning whether your clinicians might fall into this group, definitely check their MPI, and you can also get the list of patient-facing encounter types on the qpp.cms.gov website. The next special status is hospital-based. These are clinicians that furnish at least 75% of their eligible encounters in places of service 21, which is inpatient, 22, which is on-campus outpatient, and 23, which is emergency department. Those clinicians, again, are considered hospital-based. The next are small practice clinicians. Those are clinicians in practices of 15 or fewer eligible clinicians. And eligible clinicians are clinicians that are either MDs, DOs, nurse practitioners, physician assistants, chiropractors, dentists, surgeons, ophthalmologists, certified registered nurse anesthetists, and clinical nurse specialists. So lots of different practitioner types, but they're all considered eligible for this program. Rural clinicians is a designation that is applied based on the zip code in which you practice. That zip code must be identified as rural with CMS. And then health professional shortage area clinicians are also based on where you practice and whether CMS has determined that that area has a health professional shortage. You would be identified. That's not something you can apply for. CMS would just provide that to you based on the special status. As you can see, there are two columns. Excuse me. There's a status for clinicians in the practice, so that's just that individual, that single clinician. There's also a status for the practice. So these really are two separate identifications, and this is where it depends on whether you decide to report as an individual or if you decide to report as a group. If you decide to report as a group, you might not get the same changes to your reporting. Each of those statuses has a slightly different reporting requirement. So if the practice is not designated as hospital-based or non-patient-facing, then all of those clinicians would be required to report advancing care information, which we'll talk about in a minute. If you're a small practice clinician or rural or a health professional shortage area clinician, you need to report on slightly fewer improvement activities, which again we'll talk about in just a couple minutes. Next slide, please. So as I mentioned, small practices are considered to be practices with 15 or fewer eligible clinicians. Their special status is that they report on 1 to 2 improvement activities. This is dependent on the weight of the activity. Activities are weighted as medium or high. So this would be 1 high-weighted activity or 2 medium-weight activities in order to achieve the full improvement activity score. Also, clinicians, as I mentioned, in rural or HIPSA practices also report on 1 to 2 improvement activities. Next slide, please. With the 2017 final rule, CMS introduced a tremendous level of flexibility in reporting. They called it the pick-your-pace reporting options. So I'll briefly go through the different reporting options, and then we'll talk about each performance category and how you can achieve success and identify what you need to do in order to report. So the first option, which I tell everyone, please don't consider this, is the do-nothing option. You would basically completely forego reporting, and you would earn a 4% negative payment adjustment on all of your Medicare Part D claims. I'm really hoping that nobody selects this because reporting for this year is very flexible, and we are here to help and make sure that you're successful. So the next option, we call it crawl. CMS often refers to it as test. This is where you're basically testing out the program. So you earn roughly three performance points by reporting on any one of the following categories. So it's one quality measure, and the bare minimum that you would have to report would be one quality measure on one patient for one instance. So that's great if you're not really sure how you should be performing. Maybe you don't have the resources in your practice to report fully. You can definitely test out the program, avoid a penalty by reporting on that minimum level of data. We do, however, highly recommend that you don't report on just one single patient, because if that one single patient happens to be excluded from reporting on the measure you've chosen, then you would then fall into the non-reporting group and be eligible for that penalty. So we often recommend roughly 20 patients in your denominator to have a buffer to make sure that you're reporting adequately, and that if there's any issue with patients being excluded or not eligible for the measure you've selected, you have that buffer again. Now, you can report for anywhere from a single instance up to a full calendar year. It's however you determine you want to participate. The next option is to report on one improvement activity. There are about 90 to choose from. We'll talk about them a little more in a minute. You would need to report on that improvement activity for no less than a 90-day reporting period, and that reporting period would have to start no later than October 2nd. So, as you can imagine, we're past that October 2nd deadline, but there are some improvement activities that you might have been working on throughout the year that you could still claim as your work for the reporting period of 2017. One example would be if you're participating in the prescription drug monitoring program. Oftentimes that's an annual registration. So if you already registered for 2017, you could utilize that as your improvement activity for the year. If you are familiar with meaningful use and you have a robust electronic health record that can pull data relatively easily, you might consider the next option, which is reporting on at least the required advancing care information-based measures. Depending on the certification year of your electronic health record, you might have either 4 or 5 measures, and we'll talk about those again a little more in a minute. For this, you would also be required to report on no less than 90 days of data. That final 90-day reporting period for 2017 began October 2nd. Again, by reporting on this minimal amount of data, testing out the program, you would avoid a negative payment adjustment. You more than likely wouldn't get any sort of positive payment adjustment, but you wouldn't get that 4% negative. Next slide, please. The next reporting case we refer to as WAC. CMS often calls this partial year reporting. By reporting on this reporting case, you would earn somewhere between 4 and 69 performance points. You would achieve these performance points by reporting on sort of any combination of the next couple elements, either 6 quality measures, at least 1 being an outcome or high priority measure. Again, 1 to 4 improvement activities, and that's dependent on the size of your practice and the weight of the activity you select. And then no less than the required advancing care information-based measures. Typically, you would be reporting for no less than 90 days, and that must start again by October 2nd. By achieving 4 to 69 performance points, you would fall into that small positive payment adjustment bucket. And more than likely, that would be roughly 1% or so of your Medicare Part D claims. The MIPS program is a budget-neutral program, so any monies collected from those receiving penalties is what pays those receiving a positive payment adjustment. The next case is what we're calling RUN, or CMS often calls it full year reporting. Full year reporting is a little bit of a misnomer. You don't actually have to report for a full calendar year. So by reporting this case, you would be earning 70 or more performance points, same performance requirements as before, so the 6 quality measures, at least 1 outcome or high priority measure, 1 to 4 improvement activities, again, depending on the practice size and the weight of the activity, and then no less than the required advancing care information-based measures. You would be reporting for at least 90 days or up to a full calendar year, and the key part here is that you only have to report for 90 days. If you can achieve that 70-plus points in the 90-day period, then 90 days is an adequate amount of data. By achieving that 70-plus points, you would fall into a moderate positive payment adjustment, which could be anywhere up to 4% increase. And then you would also have the opportunity to receive what CMS is calling their exceptional performer bonus, which is a pool of $500 million that was set aside over the course of 5 years to pay all of those in this group that are considered to be exceptional performers. Next slide, please. We'll now talk about the MIPS performance categories that I just briefly outlined. So quality counts for 60% of your MIPS score. Advancing care information is 25% of your MIPS score. Improvement activities come in at 15% of your MIPS score. And then for this 2017 transitional year, cost is at 0%. But we'll talk a little more about some changes that came with the final rule and what to plan for next year. Next slide, please. Some key decisions that you should start thinking about. If you haven't done any reporting or any preparation yet, it's not too late. You can still be successful and avoid a payment penalty. If you've already started planning but aren't really sure where you should go next, keep these questions in mind and maybe think about how you're going to report. So the first question is what I already talked about with the special status. are you reporting as an individual or as a group? And if you report as an individual or group, do you have any of those special status designations that would change what you need to report on? Next, what reporting pace have you selected, or do you think maybe you want to select? If reporting is all new to you, maybe that crawl or testing out the program is the best way to avoid a penalty. Or if you think really you want to go for a little more of an incentive and try to achieve that lock pace where you're submitting for 4 to 69 performance points, we're happy to help you with that. Or if all of this seems very familiar, you've done well with PQRS and meaningful use in the past, and you go for the run. You want to get the 70-plus points and the maximum possible payment adjustment. Next, it's really important to identify what submission method you'll use. So different submission methods are available for different performance categories. We'll talk a little more about what's allowed under each, but you have the option to report via claims. There will be an attestation portal coming, EHR Direct, Registry or Qualified Clinical Data Registry, or the CMS web interface. And I'll talk a little more about those in a minute. As I mentioned before, have you previously participated in PQRS or meaningful use? Do those quality measures or advancing care information with the EHR implementation, do those all seem very familiar? How does your data look? Can you pull reports? Do you perform well typically? If so, you might be able to achieve more points than maybe you thought initially. And then I always mention supporting documentation. All of these programs, anytime you receive any sort of incentive payment from the government, they are eligible for audit. So be sure to keep any supporting documentation to demonstrate your performance or that you've achieved a specific measure. Keep that at least for 6 years. CMS does have up to 10 years to come back and audit you, but make sure you have both. I always recommend a hard copy and an electronic copy, just so you're not hunting around for that data should you get audited. Next slide, please. So now we'll talk a little about quality. So quality, as I mentioned, accounts for 60% of your final score in this transition year. There's over 270 measures to select from. There's about 30 specialty measure sets you can also look at if you're a specialist or would like to look at more specific measures for a certain group. You can report for data for as little as that single instance, so that's under that crawl piece, up to a full calendar year. If you start reporting for a 90-day period, again, that's no later than October 2nd. Under the quality category, if you're reporting as an individual, you do have the option to report using claims-based reporting. So that would be adding an appropriate CPT or G code to your claim and then submitting that to CMS. You can also use your EHR directly if they have that capability. They might also use a data submission vendor, so definitely check with your vendor to make sure they can support that option. You can also use a registry or qualified clinical data registry. If you're in a large group of 25 or more eligible clinicians and you registered with CMS last year by no later than June 30th, you could use the CMS web interface. That's a set of 15 predetermined measures. And if you're in a group of greater than 16 eligible clinicians, you will have an all-cause readmission measure pulled directly from administrative claims, but just know that is being calculated for those larger practices. Next slide, please. So how's quality calculated? You get the total number of points earned per quality measure. Each quality measure is dependent on the submission method you select, so whether it's claims or EHR or registry, has a different performance threshold that gives you a specific number of performance points. It's a decile scoring system. So let's say you perform at a 14% on the hemoglobin A1C poor control measure. For each of those different reporting methods, you earn a different number of points. So it could be 6 performance points for one, 7 performance points for another, and maybe 9 for the last. So it doesn't necessarily stay consistent for each reporting method. So it's really important to know where you plan on reporting, what performance you're targeting, and how you'll be submitting your data. There are opportunities for some bonus points. If you utilize an EHR and you report end-to-end, which means there's no manual abstraction, then you can earn an additional 1 point per measure, up to 6 performance bonus points. If you report on additional outcome on high priority measures, you can also earn 1 to 2 additional bonus points per measure. They're capped at 60%. Obviously, that's the max for the performance category score. And we calculate them by taking total points earned per measure plus bonus points over maximum, and that gives you your score. Obviously, nothing over 100% of that 60. Next slide, please. So some quality measure considerations. Obviously, did you previously report on PQRS or meaningful use? They both have quality measure components. Have you identified the measures you're planning on reporting? Have you looked over what's available on the QPP.cms.gov website? Are you using a specialty measure set? Oftentimes, if you're a specialist, the specialty measure sets require reporting through a registry. So just be aware if that's the route you're planning on taking, you'll need to be looking at what registries can support those specific measures. Again, do you have specific target category performance? Are you looking just to avoid that penalty, or are you looking to achieve maximum performance to get the most possible points? Do your clinicians or practices know the workflows they need to do the specific documentation to support reporting? We've had cases where practices are doing a great job evaluating the patients for everything, really holistic care. However, they document everything in a free text note, which makes it nearly impossible to pull that data to actually report. And then, of course, can you pull the data reports, and what does that data actually look like? Next slide, please. Advancing transformation, again, this is the meaningful use measures carried over. The total performance category weight is 25% of your MIPS score. You can earn up to 155%. I always say people think I'm crazy probably, because how do you get 155% of anything? So the way this category is scored is that 50% of that 25% comes from the base required measures. If you don't achieve success in those base required measures, you cannot earn any of the performance or bonus percentage points. So 50% you automatically get as long as you pass the base measures, and then you can get an additional 105% based on performance and bonus. You must report for 90 days, and you can start no later than October 2nd. That's the last 90-day period in the calendar year of 2017. For advancing transformation, you have an additional reporting option. There is an attestation portal that will be made available by CMS. We've heard it's coming early 2018, like January, first week in January. And unfortunately, there isn't a lot of additional information on requirements and what the actual attestation process will look like, but please stay tuned if you're thinking about using that option. Again, you can always use EHR Direct, Registry, QCDR, or CMS Web Interface. Again, make sure your EHR vendor can support this method. A lot cannot. So if you're planning on going that route, check with your vendor. Next slide, please. So a quick breakdown of how the scores are calculated. As I mentioned, there's two required measure pathways dependent on the certification year of your EHR. If you have a 2014 certified EHR, you will be reporting on the 2017 Advancing Care Information Transition Measures, which are on the right. That's a set of 4 required measures. If you're reporting on the 2015 certified EHR, you have the option to report the Advancing Care Information Measure set, which is the 5, or the 2017 Transition Measures. It's up to you what makes the most sense. If these measures look familiar, it's because the Advancing Care Information Measure set is really meaningful use stage 3, and the 2017, oops, we jumped ahead. You can go back a slide. The 2017 transition measures are meaningful use stage 2 modified. Again, if you don't report and don't achieve the required percentage for the base measures, which is at least 1 patient in the numerator, then you would be ineligible to earn any additional performance points. CMS in the 2018 final rule that just came out did apply 2 exclusions to the 2 base measures on each measure set, which is the Health Information Exchange for the Electronic Summary of Care. If the clinician or practice has fewer than 100 referrals or transitions during the reporting period, they would be excluded from that measure. Or if you have fewer than 100 permissible e-prescriptions, then you would also be excluded from that measure. So 2 exclusions. Next, we come to the performance score. So based on the measure set you select, there are either 7 or 9 additional measures that would give you up to 90 performance points, getting you even closer to that 100% of the 25%. Next slide.
Leela, I just want to make sure I'm on the right side. Which one is supposed to be showing right now?
It should be the bonus is the next.
Bonus.
Mine just froze. Is it on the bonus? Oh, actually, so it's a score. Sorry, it's the breakdown of the score.
So, is this with the
3 bars?
3 bars. Okay. MIPS scoring for advancing care information.
Yep, thank you. Sorry, we're
Okay.
working off 2 computers. I couldn't get into the WebEx. So for the advancing care information performance score, it's calculated by that base score plus the performance score plus the bonus, which comes from either reporting on an clinical data registry or population health registry or utilizing your EHR to implement improvement activities. Again, you're capped at 100%, so even though there's an opportunity to earn 155 percentage points, you're capped at 100. Next slide, please. There is an advancing care information hardship exemption. So clinicians that are experiencing significant hardship, so that's either insufficient internet connectivity in the area where you work, if you've experienced extreme and uncontrollable circumstances, if your EHR maybe has been decertified during the reporting period, you can submit an application to CMS. If it's approved, your advancing care information category would be reweighted to 0, which would make your quality category 85% of your MIPS score. For clinicians that are considered to be hospital-based, non-patient-facing, physician assistants, nurse practitioners, clinical nurse specialists, or certified registered nurse anesthetist, then they automatically all have their advancing care information performance category score reweighted to 0, and quality will become 85%. Now, that's if they're reporting as individuals. If those clinician types are reporting as a group, there is a specific condition. So hospital-based clinicians, in order to have the entire group's advancing care information category score reweighted to 0, the entire group, 100% of those clinicians, would have to be considered hospital-based. For non-patient-facing clinicians, 75% of those clinicians in the group would have to be considered non-patient-facing in order to have the entire group's advancing care information performance category score reweighted to 0. So a couple little things to keep in mind about group and individual reporting. Next slide, please. Couple considerations. So again, have you previously reported on meaningful use? If so, all of these measures should look very familiar to you. Do you have the workflows in place to capture the data necessary? So is it going into a discrete field or are you writing it in a free text note? What's your category performance? Are you looking just to get the base score? Are you looking to get bonus points and performance points? Can you pull your data reports? And then again, do you have any of those excluded clinician types? So do you have the hospital-based or non-patient-facing clinicians, and how are you going to account for those changes? Next slide, please. Improvement categories account for 15% of the final MIPS score. This is a new performance category for MIPS. I like to call it quality measures on steroids. So it's kind of looking at your whole process and workflow and how you engage your patients and how you care for patients across multiple comorbidities and really looking at all different aspects of the care continuum. All improvement activities must be implemented for no less than 90 days. Again, practices with fewer than 15 eligible clinicians have to report on 1 to 2 activities to achieve full credit in this category. Practices with greater than 16 eligible clinicians report on 2 to 4 activities to earn full credit. If your practice is patient-centered medical home recognized, then that entire practice, if you're reporting as a group, would receive full credit in the improvement activity category. There are over 90 improvement activities to choose from in those 8 categories at the bottom. Obviously, CMS is putting a great emphasis on beneficiary engagement, patient safety, care coordination, population health management, behavioral health, and practice access. You'll see a lot in those different categories. Next slide, please. The improvement activity section, a couple things to consider. So we've seen activities that range from more formalized quality improvement meetings with the administration of practices to As I mentioned, implementation of the prescription drug monitoring program. We also see programs with clinicians that we work with here at the QIN-QIO that have implemented diabetes self-management education or antibiotic stewardship programs. But some things to consider. So how do you engage your patients in their care? That's getting beneficiaries engaged. Do you include them in a patient and family advisory council? Does your practice have specific quality improvement programs in place? So do you meet routinely? Maybe that PFAC team comes together with your practice administration and talks about how to improve quality. Maybe you administer different CREST gaining surveys or the AHRQ patient safety culture survey. What do you do to coordinate care for your patients with chronic conditions? Do you have a special care coordination program for your chronic heart failure patients or your diabetic patients or patients with COPD? Or do you have care coordination programs for all your patients, regardless of what conditions they might have? You utilize your EHR to document patient reported outcomes or care plans. You can take some bonus points here if you're utilizing your EHR. There's actually 18 improvement activities that incorporate the EHR and give you up to 10 advancing care information bonus points. So a great way to get double credit for things you might already be doing. And does your practice have those self-management educational programs or materials available? Are you trying to get patients really engaged and involved in their care, self-managing, identifying when they need help, some things to consider. Next slide, please. So I mentioned cost is 0% of the final score for MIPS in 2017, so there's no reporting requirement. Clinicians can look at their quality and resource utilization reports for 2017 to see how they're performing, but there's no actual data or penalty applied if you don't report anything in cost. But, next slide, please. Keep in mind, cost is coming. You should definitely have an idea of how you were previously assessed and review those QRUR reports. You should also start looking at how your utilization and cost containment strategies are. Have you reduced costs? How are you in line with what CMS was expecting for costs? In 2018, which I'll talk a little more about later, but in 2018, costs will become 10% of the MIPS score. It will be evaluated by an average of 2 measures. They are pulled on 12 months of data, and it's the Medicare spending per beneficiary measure and the total per capita cost measure. Luckily, CMS did remove those 10 episode-based measures, and they are looking for comment on the development of some new episode measures, but cost is coming down the line. Next slide, please. So the final MIPS score is calculated by taking your quality performance plus your improvement activity performance plus your advancing care information performance and multiplying that by 100, and that gets you whatever your score might be. Next slide, please. So, going back to that initial table in a slightly different format, if you earn 0 performance points, you are going to receive a 4% negative payment adjustment. If you achieve 3 performance points, you would be in the neutral. So you're not getting a positive payment, you're not getting a penalty. If you're in the 4 to 69 performance point bucket, you would be getting a small positive payment adjustment. And if you're in the 70 plus performance score, then you would be getting that modest positive payment adjustment and an opportunity to get some of that $500 million set aside for exceptional performers. Next slide, please. So with all that fun of 2017, who can forget about 2018? So the Quality Payment Program Year 2 final rule was released November 2nd of this year. Next slide, please. And it brings about some pretty significant changes. So we talked initially about avoiding that penalty by earning 3 performance points. For 2018, you will need to earn 15 performance points in order to avoid a 5% negative payment adjustment. So the payment adjustments went from 4% in 2017 to 5% in 2018, and they will continue to increase to 7% in 2019 and 9% in 2020 and beyond. Next slide, please. As I mentioned with the low volume threshold, for 2017, the low volume threshold is $30,000 in Medicare Part B claims and 100 Medicare beneficiaries cared for annually. For 2018, CMS has significantly increased this, which will obviously mean a fair number of small and solo practitioners will likely be excluded from reporting. So the low volume threshold increased to any clinician that submits fewer than $90,000 in Medicare Part B claims or sees fewer than 200 Medicare beneficiaries annually, you would not need to report data. As I mentioned with that eligibility determination tool on the qpp.cms.gov website, if you look at the tool right now, so today, you won't see whether you're included or excluded for 2018 based on this increase in the low volume threshold. Because we're still in the 2017 performance year, that is showing you data for clinicians who are eligible or excluded based on 2017 data. Our expectation is hopefully that CMS will update that with the change to the low volume threshold exclusion, hopefully sometime in January, maybe as late as February or March. So definitely keep your eye out because all of that data will get updated to show whether you're included or excluded for next year. Next slide, please. As I mentioned, the cost performance category is now going to be 10% of your MIPS score, and it will be calculated off of an average of those two measures, the Medicare spending per beneficiary and the total per capita cost. It is pulled from a full calendar year of data. Nothing you need to submit, CMS will pull that for you automatically. Next slide, please. A nice change is that in the 2017 final rule, clinicians were all required to be on 2015 certified electronic health record systems by 2018. CMS has relaxed that requirement. Clinicians are allowed to continue utilizing their 2014 certified EHR for another year. If you are part of a practice or a group or a solo clinician that upgraded or implemented a 2015 certified EHR, you will get 10 percentage bonus points for doing that additional work. So a little bonus if you've already upgraded to 2015. Next slide, please. As I mentioned, there's increased flexibility for small practices. So small practices are those practices with 15 or fewer eligible clinicians. If you report data for at least one of those performance categories, so quality, improvement activities, advancing care information, or cost, you can earn a 5-point bonus to your final MIPS score. There's additional significant hardship exemptions available in the advancing care information category. So similar to what's available this year for those extreme and uncontrollable circumstances, there will be an application available for clinicians in small practices to get a hardship and have their advancing care information reweighted to 0, which would make quality 75% of their MIPS score. We didn't talk about it a lot, but the quality category for 2018 does have a new requirement for an increased level of data completeness. Clinicians that are reporting on measures must have at least 60% data completeness in order to achieve 3 to 10 performance points on those different measures. If you don't meet the 60% data completeness requirement, you can only receive 1 point per measure. So pretty significant. Definitely need to make sure you're reporting on the adequate patient population. However, if you're in a small practice, even if you don't meet the data completeness requirements, you can still earn 3 performance points. You are capped at 3, though, but you can still earn 3. Next slide, please. So, here are some resources. This is a website at the top, the New England QIN-QIO macro website. We also have an Ask a Question link. There's the link to the CMS website, the QPP.CMS that I referenced, and of course a link to our New England Rural Health Roundtable with lots of events and resources available there. Next slide, please. Those are my crazy dogs. Any of you who know me know that I always talk about my dogs, and we will open it up for questions. Morgan will be monitoring chat for me, and if you would like to ask a question over the phone, you can press #6 to unmute your line.
So, Leila, we actually have one question in chat right now that I can see from Kathy. If you don't agree with what CMS shows on the QPP website, will you have to correct it with CMS before submitting MIPS data next year?
So I believe you're referring to what your determination would be, and that data is pulled either from claims or off of the PCOS website. So you could always correct it with CMS. I don't know how quickly they're correcting that type of error. I guess I'd be interested to hear, does the change mean that you'd be required to report less, or would it be meaning that you're required to report more if you change your status? So it's up to you. You need to reach out to CMS, and I can tell you right now that process is probably complicated in what they're going to require, but you could definitely change it with CMS.
Excellent. We do have a couple questions rolling in now. So this is from Shelley. How do you find a registry for reporting?
Yeah, great question, Shelley. Thanks for asking that. So if you go on to that qpp.cms.gov website, they've actually changed it around a little, and I apologize. They send you to another website for their resources now. But if you go to the far right-hand side on the top and click on the About the Program, you'll see a resource library link. If you click that, and then there's another link in there, it will take you to a CMS page. If you scroll almost all the way to the bottom of that page, there's a listing of all of the qualified registries and qualified clinical data registries through CMS. It's a big PDF. Depending on whether you're a specialist or what type of practice you have, there might be a specific registry that really works well with your practice type. I would just caution you, be sure to check. There's a couple columns. I wish I could pull it up on the screen for you. It'll show the performance categories that are supported by that registry. Make sure that it supports all of the categories you're planning to report using the registry. And then if you want to report quality data, there's also a column that shows the quality measure IDs that are supported by the registry. Not every registry can support every measure. So be sure to check to make sure that the measures you want to report are supported by that registry. Registries also often cost, we've seen anywhere from free for certain society-supported registries to upwards of $700 per clinician. So just look to see what makes sense for you financially if you have a large practice, whatever the case is, but evaluate those. And unfortunately, there's a ton, so it really depends on what you're looking for and your practice type.
Excellent. So we have another one in chat from Rachel. She said, just want to verify, NPs are exempt from ACI in 2017.
Yes, Rachel, that is correct. Nurse practitioners are exempt from advancing care information in 2017.
And that's all the questions we have in chat. So right now, again, you can press #6 to unmute your line and ask a question over the phone, or you can type one into chat.
Great. And while we're waiting for additional questions, I'll have you just jump one slide further is my contact information. If you have any questions that you don't want to ask over the phone or in chat, feel free to send me an email. And then the last slide is that we have some great social media content. We have a Facebook page, a LinkedIn page, and a Twitter page now. We post lots of different articles, events coming up, different resources. So definitely check those out and follow them if you'd like to be kept up to date on the content that we have available.
We just had a question come into chat. How does this apply to ACO MSSP Track 1? Will you have a webinar focused on ACO?
I missed that last piece. Did it say, do you have a webinar focused on ACO?
It says, yeah, will we have a webinar focused on ACOs?
Yeah, so great question. We actually did a webinar a couple months back in September with the Massachusetts Health and Hospital Association on ACOs or APMs specifically, but we're more than happy if that's content you would like. We can definitely plan on scheduling something in the next month or two to get you some ACO, APM specific content. Absolutely.
Oh, sorry, I was talking on mute. I just said that Radhika put the link to the registries in chat, so everybody should be able to find that. And then Shelley asked another question, which performance categories does attestation through the CMS portal apply to?
Yes, so great question. Attestation is only available for the advancing care information and the improvement activities category. Unfortunately, CMS is not allowing attestation of quality measures for this year or next year. And I want to briefly mention, we are doing a 6-part series with the Rural Health Roundtable and the New York Rural Health Association. So be sure to be on the lookout. We'll have great content on various topic areas. The next content will be coming out January 10th, and it's around safe care transitions and medication safety. So if you have interest in either of those topics, looking at reducing readmissions and the opioid crisis, definitely tune into that because we'll have some great speakers talking about that content.
We do not have any more questions in chat, Eva.
Great. We'll hang them on for a few more minutes. Feel free to type questions into chat or, again, #6 over the phone if you would like to ask them over the phone. And anyone who's out there listening who hasn't planned for reporting yet but might be eligible, please don't hesitate to reach out to us if you have any questions about reporting, avoiding a penalty. Our goal is to make sure that all of the clinicians that are eligible across New England and really anywhere across the country have the resources that they need in order to be successful in reporting this year under the MIPS program or under an APM if that's the route you're going. So no question is a dumb question. We've heard all matter of questions related to all different practice types, practice sizes, EHR situations, paper-based reporting. Please don't hesitate. We want to make sure you're successful.
So we did have a couple more questions come in. I put the slides up to Leader's contact information again. There were some questions about the slides for today. So I am putting a link in chat right now for that. And then also we have another question from Helen. The 2018 rule shows 90,200 threshold. How does that work if a clinician did poorly in 2017 but then does not meet this threshold in 2018?
Yeah, so that's a great question. We've heard that a lot about not quite that exact question, but you have to report this year, 2017, if you're excluded for next year. So if you don't perform well this year, so I guess not performing well would be not reporting, so getting the 4% penalty. That penalty is applied in 2019, so there's a 2-year delay on when penalties or positive payment adjustments are made. So you would report or not report this year. You see your positive or negative payment adjustment in 2019. The way we're explaining to clinicians to think about the different program years and whether you're included or excluded is really to think of them as 2 separate programs. So this year, 2017, again, that low volume threshold is $30,000 in Medicare Part D claims and 100 Medicare beneficiaries. If you don't report, you're seeing a negative 4% penalty in 2019. Now, with it low volume threshold increasing to 90,000 in Medicare Part D claims and 200 Medicare beneficiaries annually next year, a great number of those that were included but just barely included this year will be excluded next year. Then you would be excluded next year. You wouldn't need to worry about reporting, but that means that you wouldn't see any payment adjustment, positive or negative, on your 2020 Medicare Part D claims. So again, it's always a 2-year lag, and I apologize, I skipped over that slide because I wanted to talk about the eligibility. But there's a 2-year lag in when you perform and then when you see the actual payment adjustment. And the low volume threshold might go up and down over the next few years. I don't know what will happen in 2019, if it will stay the 90,000 and 200, or if it will go back down to somewhere in between the 90 and the 30. It's really hard to say with the rulemaking where that will all fall. But it's really important to make sure clinicians are prepared. We'd also say, even if you're included this year and you do just the bare minimum to avoid the penalty and you're excluded next year, definitely try to continue the progress you have with quality reporting and looking at how to improve your practice, because just because you're excluded this year doesn't mean you'll be excluded next year, and you don't really want to fall out of practice with reporting on all of these things and having those workflows in place. So definitely try to maximize the opportunities you have and put into place new work if possible. And again, we're always here to help. All of our work and technical assistance is offered at no cost, so we're happy to just work through whatever your issue might be.
So there are no more questions in chat, Lila.
Great, thank you. So we have a couple more minutes. We'll just hang on line for 5 or so more minutes if anyone else has last final questions.
Oh, Lila, another question came in. Can you speak to the pros and cons of individual versus group reporting? I have 2 doctors in my practice.
Yeah, so that's a great question. I'm assuming with the 2 physicians or whatever kind of clinicians they are, that they are both eligible. So it really depends on a couple things. So individual reporting oftentimes makes sense for the small practices, or if one clinician is doing extremely well, whereas the other clinician might not be doing quite as well, and you want to maximize the possible positive payment adjustment. Now, that also holds true for group reporting. The group reporting is great if you're trying to reduce the administrative burden. So if you have 2 to 200 clinicians, it doesn't really matter, anywhere in there. Reporting as a group, you get to aggregate all of your performance for the various measures that you select. So obviously, reporting on one single aggregate for your practice versus 200 or 2 or 15 or however many clinicians takes away a lot of that time that you would need to attest or submit. Also, in the example I mentioned with a clinician performing well versus one not performing quite as well, having that clinician that's performing well might help even out that clinician that's not performing quite as well. But again, you wouldn't necessarily get as high a positive payment adjustment if you're trying to balance out sort of lower performance with higher performance. We also see a lot of practices consider group reporting when they have trouble pulling the data for one clinician specifically. It's easier to report as an aggregate. If you have clinicians that are excluded, so let's say one clinician is included in reporting and must submit data, and one clinician is excluded due to the low volume threshold. If you report as a group, all of the clinicians in the practice, regardless of whether they're included or excluded due to the low volume threshold, would be included in that group's reporting. So just something to consider. Again, it's not necessarily a one-size-fits-all easy answer. It's really dependent on a couple things within your practice. But if you have specific examples or questions about performance that you want to run by us and try to figure out what makes the most sense, we're definitely more than happy to help you with that. But it's really kind of what works best for you and what makes the most sense.
Those are all the questions for now, Lila.
Great, thank you. Well, and it looks like we're 1 minute away from 12:30, so we will wrap the call. But definitely feel free to send us an email if you have additional questions. And thank you all for participating today.